Welcome to the Beat Pain Podcast, where we learn what actually works for pain relief, staying healthy, and navigating the medical world. I'm your host, Brandon Cope. Do you ever get confused about how your pain works or what is happening with your anatomy? It can be frustrating. My guest today will explain what you need to know about pain and the body. She is an anatomy professor at multiple different schools, a neurokinetic therapy instructor, and creator of the Immaculate Dissection courses. You can learn from her by going to neurokinetictherapy.com or immaculatedissection.com and taking a course. I'll have links in the show notes. Please enjoy my conversation with Dr. Kathy Dooley. Dr. Kathy Dooley, thank you so much for being on the podcast today. It's just an honor and a pleasure to have you on. We talked a long time ago in another podcast that I had with NKT, and I'm so thankful to have you on this podcast here today. I know you've got such a great background working with so many different things, and you've got so much to share with people. So I just really appreciate you being on today.
Oh, well, thank you. It's my honor and privilege.
Thanks. So, you've taught anatomy at many different schools. I mean, I'm almost afraid to name all of them, or because you've taught at so many different places. I feel like I might not say all the list of different places you've taught at, but you're such an educator. I mean, you love teaching, and it's really interesting that now you're teaching a new course called Immaculate Dissection, which I'm so excited to talk about with you. And this course is it's not like a normal learning format for anatomy. You're doing something really different. So, why are you going so outside of the box in this new course? And is there a need for anatomy to be learned in kind of this new format? Tell us a little bit more about that.
There is a desperate need to learn functional anatomy as it's applicable to people, clients, and patients. And somewhere along the way, anatomy got lost. One of the very disheartening pieces of me working in the university setting is watching anatomy programs get sliced. In how
choice word
they're getting dissected away from the curricula, and it's devastating to watch because as someone who finds it ultimately the reason why I'm a decent practitioner and why I continue to grow, my entire practice is based upon anatomy and the understanding of it. And to watch it get cut a piece, just cut apart over and over and over again, it's been really hard. And so my mentor had sat me down and said, look, anatomy's dying, don't let it die. And I take him very seriously, and he was a brilliant surgeon, and I feel a duty and an honor to keep it going, and I will not let it die on my watch.
Yeah. Anatomy is dying. That's profound to say, not only because most anatomy is looking at literally dead anatomy. I mean, literally people are looking at, a person who has passed on, and they're looking at those bodies. But, you're bringing in a new perspective, looking at people who are moving and doing different function and doing different things with their anatomy.
Yeah. It's the one thing about the dead is they don't move, hopefully.
Yeah.
Yeah, that's when we learn from a dissection experience, it's wonderful. I mean, this year I hit 1,900. So 1,900 cadaver patients that I've been able to observe, and it's been an honor and privilege to be able to do so. But the carryover into understanding how that will help the client, sometimes there's a big missing piece there. The problem I have is that most anatomy courses are very organ insertion, innervation, blood supply, and not really an assessment process, a palpation process, a standard operating system to be able to understand why anatomy should matter to the client in front of you and even to the person who's doing the assessing.
Yeah, it's true. I mean, you say palpation, and that's something that I know you and myself, we work with a lot, making sure we get hands on the person. And when you're looking at somebody who, is not moving, somebody who is dead, and you're working on their body on a cadaver and you're touching, I mean, that's a whole different palpation experience than on a living, moving, blood is pumping body. You're going to feel different things are going to be happening with, movements and muscles and engaging. That palpation is so important. And if people are going through, if a doctor is going through school and they're learning anatomy and they never get that kind of experience, that's going to be a whole different understanding of anatomy. And so that's great that you're providing that for people.
Absolutely. And even though I've done fresh tissue dissection and embalmed specimens, it is, even in fresh tissue, a 100% different, because most of the time when we're palpating, the skin is on. So
Yeah,
it's
right.
a completely different palpatory experience. And it's very important to teach people not just to palpate, but to educate the person they're working with to learn how to palpate themselves. And I think it takes us away from being this person that says, I'm in pain, I am in discomfort, let me stretch it out, to I have discomfort, how can I bring objectivity to this subjective experience?
Yeah, absolutely. And,
Yeah.
like you said, we're not peeling the skin back on people, but you do have somebody in your courses who's doing amazing artistic renditions of the anatomy underneath. And you're giving people a great visual to what's going on there without having to do any kind of peeling back of skin or any cutting of any kind. That's really, really cool to give people that hands-on experience, to give people the visual of the anatomy. I mean, I'm kind of just curious, how is that working with that artist and creating that those pictures of people's bodies?
Oh, Danny is beyond brilliant. And we talk a lot about how people assume that he's just talented, like it was rained upon him like a deus ex machina. It's just, no, Danny and Anna and I we work tirelessly to understand the anatomy ourselves. And then Danny, the way that he learns is through artistic expression, and he wants to provide a visual feast for people that are visual learners to be able to understand the content that Anna and I deliver. And he has learned so much in the last 5 years of us doing these seminar series.
Yeah.
And his art has changed dramatically since the beginning. He talks about how much he's learned, and that's how he applies his learning. And it wouldn't be Immaculate Dissection if it weren't for you being able to have a lot of great visuals.
Yeah, that is so cool. So, I just want to understand here, kind of coming back to how schools, the anatomy programs are dying and you're creating something new. I mean, what would be in your like perfect future, your hope for anatomy education? Would they have more courses like what you're doing, but inside of a university? Or, what should be, in your opinion, what should be the future of anatomy education?
I mean, I'm pretty biased. I think it should be Immaculate Dissection. I think it should be watching things move, analyzing the way that things move, not just saying, hey, the tensor fascia lata does flexion, abduction, and internal rotation. I mean, those are arbitrary statements. It's really about understanding the biophysics of what's happening during human movement. And I think that is complicated in the beginning. And I think that the only way to make it easy is to make it to study.
Yeah.
And to continue studying. And for me, it's a constant study. And it's funny how the more you study, the more you understand what you don't know, and the less hubris you have, and the more you want to investigate.
Yeah.
And I think that the perfect way to study anatomy would be, of course, doing human dissection, so you can see the depth and the perception of who someone is and how they move, or how they connect, and then watching how they move through human analysis. I think that's a huge piece. And I think diagnostic ultrasound, that several of the universities that I work for are starting to use for educational purposes. You can actually watch the anatomy move under imaging, but you can't do it on MRI. You can't do under a radiograph, to things that have their uses, but also have massive limitations.
Yeah.
And so I think that, we need to use multiple levels of anatomic study. And I think that what we're doing in Immaculate Dissection should definitely be one of them. It's underutilized, which is why we created the course.
Right. That's great. I mean, it's great that you have brought yourself into the depths of anatomy so much to see, where things were missing. And then you've created the course to fill in those gaps for people and help people get outside of the box of typical anatomy, become different kind of practitioners, learn different things that maybe they, from different angles, seeing stuff in new light. That's really awesome. And, as a chiropractor, you operate differently than a lot of other doctors working with pain, and you definitely get into the movement with people a lot more than I think even a normal chiropractor would. You're doing stuff with strength and mobility and muscle testing, and you've got a ton of stuff you're doing with kettlebells. You take anatomy and you like to move people all the time. And I love that.
Yes.
I mean, why for you, you're kind of outside of the box when it comes to your anatomy teaching, but let's get into chiropractic. Why do you do things so differently as a chiropractor?
Well, I'd like to admit something really strongly, because I'm not afraid to admit in front of my classes or in front of my patients. And I advise my patients and warn them that there may or may not be adjusting happening during their visit. And so that's why I'm out of network. So I'm not forced to adjust someone that I don't think needs to be adjusted.
Sure.
So here we go. I was in chiropractic school 2004 to 2007. And I found chiropractic to be very relieving of my immediate symptoms for a while, for a few days. And when you're in a lot of chronic pain and you've been in chronic pain for years, you'll take a few days, especially something natural that's not going to hurt organ systems like NSAIDs. I was like, wow, I finally found something that gives me a couple days of relief due to this amazing thing called mechanoreception, movement reception. You start to adjust segments. It releases a chemical called GABA, which is an inhibitory chemical. It basically inhibits pain ascending to the brain. And it was amazing at first. But then I would notice that, I would get adjusted, and then I would, a couple days later, I'd get tight again. And it was really sitting wrong with me that I was spending $200,000 on an education to become a doctor in something, but something wasn't quite right. And, I'm board certified in physiotherapy also, because chiropractors are, and I was like, wait a minute, maybe I need to start to investigate other things that need to supplement this chiropractic experience. And so I started gravitating towards human movement and stability work, stability motor control.
Yeah.
And for me, a lot of the tightness that I perceived as pain, which is, pain is a perception. It's nociception, right? Pain perception. But perception can be very altered and sensitized and can be very confusing to the chronic pain patient. And I was a chronic pain patient. And so I was like, wait a minute, I got to stop looking for quick fixes. I've got to look at why my body gets this tight in the first place. Why does my body get misaligned? And so I started combining my chiropractic efforts with understanding stability motor control. And I don't think that I really understood things as well as I could have until I met David Weinstock of neurokinetic therapy,
Right.
where his entire practice was based upon manual muscle testing, sure, but I learned manual muscle testing in chiropractic school. It wasn't about manual muscle testing. That was an envoy into a protocol. It was about understanding that stability motor control is at the root of a lot of chronic pain. It's based upon movement reception, mechanoreception, where we are in space. And the fact that my body didn't really quite know where it was in space. So it would create tightness in an attempt to stabilize me, much like when you put a parking brake on a car that's parked on a hill. It's the perception of safety. My body had the perception it was unsafe. Therefore, it created a response that tried to keep me safe. Nociception is not different. Pain reception is very similar. Pain reception is a perceived threat. It's noxious reception because there is a perceived threat to the system. It doesn't mean there's an injury. And my chronic pain patients that were like myself need that education. They need to understand that chronic pain is a perceived threat, but not necessarily and actually an injurious response. Yeah. And I did not know that going into chiropractic school. I had a lot of great teachers, neuroanatomy teachers, neuroscience teachers. They were trying to explain this to me, why chiropractic worked. But then also I knew the understanding of the limitation of just getting an adjustment, which is why chiropractors are certified in physiotherapy. We need to be able to balance things with exercise. Now, unfortunately, a lot of chiropractors don't do that. You have great chiropractors like Greg Rose, Philip Snell, Craig Liebenson that are, worldwide educating people that you have to stabilize people as much as you can mobilize them. And a lot of times they need more stability work than they need mobility work.
Right.
And so I was led by these incredible people to a practice like David Weinstock, Craig Liebenson, these people, Greg Hook, Greg Rose, these people guided me towards maybe I needed to marry my mobility corrections with stability work, and maybe a lot more stability work than mobility work was necessary.
Yeah.
And for me, that was the only way I could get comfortable. That I finally, now that I'm 41, the oldest I've ever been, obviously, but in the best I've ever felt, with the least
Wow.
amount of chronic pain afferents. I stopped believing the story that we're worse as we get older. We're worse as we let things go uncontrolled
Wow.
for a period of time.
Yeah.
It's not age dependent, it's time dependent. And when I flipped that script for myself, it took me, several years to really understand it. I wanted to teach everybody. I wanted to teach the world. I want to teach the world about anatomy, how to understand stability motor control problems, how you can understand things need an infinite balance, right? Between structures, between attachments, between nerves, arteries, veins, fascia. And the only way for me to be able to do it with a certain bone of expertise, pun intended, was anatomy.
Mm-hmm.
It's at the foundation of what all yoga instructors do, what all Pilates instructors do, what all physiotherapists do, chiropractors do, acupuncturists. No matter who we are in dealing with human movement, our commonality is anatomy. And since, I have a master's degree in it, and that's what promoted me to get a master's degree. After chiropractic school, I went right into my master's degree in anatomy, in clinical anatomy. And then I couldn't get enough. I was like, any school that would hire me, I took the job, which is
Mm-hmm.
why I didn't have much of a personal life until I was in my late 30s
Yeah, sure.
because I was in school until I was 35, just really trying to understand how I could help myself. You
Hmm.
start with you, the N=1, and you look in the mirror and say, I can't help anybody with their chronic pain until I understand my own.
Yeah.
And that's a really hard thing to face. Like, I don't know anything, and I have to admit that I know nothing. In order to be of any use to anybody, I have to admit that to myself first. And if
Mm.
I can't demonstrate this in front of a client or a patient, if I can't show them how I've risen up from a life of chronic pain into one with less chronic pain, then who am I to stand up here in a soapbox to tell them anything if I can't do a self-reflection?
Yeah.
And so it came from, the short answer to your question is it came from a lot of my own experience in chronic pain and wanting to understand how I could not feel it, how I could balance my life to not feel constant discomfort.
Yeah. That's really profound and humbling to hear. Thanks for bringing us through your own journey. And you're absolutely right. If, you know, you have to be able to have the self-awareness and humility of understanding your own pain when it comes to helping other people with their pain. And I think that, getting back into going to schools and how you said that you were spending, $200,000 going to school, but you're still in pain. I mean, there's a lot of practitioners, doctors, other people who are going through school, getting all of this education, and they don't even understand the pain in their own body,
Yeah.
And I wonder, since you are an educator, how much education should we be expecting, or what kind of process should be occurring, do you think, for doctors when they're going through medical school? I mean, what should they be learning about pain? I mean, what should they be experiencing that's helping them to understand and kind of go through that dive that you went through? I mean, is there a way that we can help our education system create something like that so that our medical professionals and our practitioners are aware of the pain they have inside their bodies?
This is going to be challenging because you're asking for uh, an educational process on a subjective measurement.
Hmm.
And much as I like to be empathic about someone else's pain, I have no idea what it feels like to be them.
Hmm.
All I can do is, I think a better way to do it would be less descriptions of pain and more descriptions of awareness.
Hmm.
And you have really great people like Lorimer Mosley, David Butler, who are working tirelessly to help people learn how to describe their human experience rather than falling down the P word, right?
Hmm.
It's very tough to describe your personal experience. I can qualify it, right? I can say, oh, I have sharp, dull, ache, radiating, non-radiating, and then I can quantify it with 10 out of 10, which is an arbitrary number. Like, patients, have a really hard time being able to use a visual analog scale for their pain. And you can give them an oswestry and have them fill out these forms, which are helpful. All these things are helpful. But when it comes to a curriculum based upon pain, you may have to go more towards the science of getting people to better describe what the experience is. And I think one of the best people that's ever helped me with that was Dr. Philip Snell. He's a chiropractor in Portland, Oregon. Fantastic guy. I went to a talk that he gave, and he was talking about low back pain. And he did a phenomenal job at describing that the relationship of like low back pain with these different type of receptors, right? He got very scientific with it. Thermoreception, chemoreception, mechanoreception. Mechanoreception being movement perception, chemoreception being like factors in the blood that can affect our experience, like inflammatory factors, like interleukin 6, tumor necrosis factor A, very scientific stuff, right? And then, our thermoreception, our ability to respond to heat or cold and how that plays a part because it's in the same pathway to the brain as pain, called the anterolateral system, right? So he was very scientific about it. I really liked that because, in a subjective environment, what my patient needs the most, I think, is a structure, an understanding of not just a way out, but a way in to understanding what their experience is actually trying to tell them. Because when I ask my patients when they come in, I'm like, well, what do you want? Why are you here? I'm like, well, I want to get out of left hip pain. And I'm like, you still think that pain is bad. It's nociception, it's nociception, but I don't have that same relationship with pain. Pain is a receptor. It is a program, and your body is doing it to try to keep you safe, right? Once you start to flip that script and description of a patient, I think that was what is needed in the curriculum, and not like, do you feel pain, but what is the pain experience like for you with your, basic, descriptors and of qualitative, quantitative measurements. But most importantly, like, let's explain to you what actually that means, what these receptors mean, and being able to value which of them are more keyed up in the patient. Like, how can I look at your blood work and determine that the things like C-reactive protein, things that you eat, things that you do, the infections that you might have might amplify your pain, and how I can help you to control your pain, manage things more with the blood versus like far infrared heat is shown by FDA approved for chronic low back pain management, right? Why is no one talking about the fact that you could actually put a heating pad, a particular kind of heating pad, on a person and help them with pain management to get their pain to dull down so I can get them to do the rehab that they're doing? I mean, I don't like to be a basement chiropractor in Midtown Manhattan in a gym that looks like a CrossFit box, being the first person to talk to someone about how they can help manage their own pain. So we have a paucity of patient educational courses as curricular-based activities for chiropractors, instructors, medical doctors, and the like. It's more of shoot this up with Novocaine, shoot this up with cortisone, shoot this up. It's not working. The research is supportive that it's failing abysmally, and yet people make thousands of dollars. I know a doctor in Midtown Manhattan that makes $1,000 per 10-minute injection that he gives. He makes $1,000 every 10 minutes. So now we have money trying to cloud, the patient experience. And I know the truth about pain killing things, right? Pain, again, is not bad. It's a symbol of something. And when you coat it, it's like covering up a rusty fence with paint. It's still rusty. And now you might even put the person in more danger because the pain reception was, again, a perceived threat trying to protect the person. So a better understanding of what nociception is valuable. So neuroanatomy should not be a 2 or 3 credit hour course over 3 months. Neuroscience of pain should be in every semester of a medical curriculum.
Yeah.
It's not, unfortunately. I can validate that it's not through being in that experience, in the medical universities. And while I see the perpetuation happening of there's pain, kill it. Before there's pain, investigate it. Investigate the why that it's there. And when I finally got down to brass tacks about why my pain was perpetuating chronically through more investigation into chemoreception, the chemical factors that are in blood, and mechanoreception, movement-based stuff, and thermoreception also. I mean, Dr. Snell's hit it right on the head. You have to look deeper. You have to investigate. You have to be the Sherlock Holmes of pain reception. And remember that pain is reception. It is perception, but it is reception, which means it has structure, it has a path, and you have to investigate it.
That's awesome. Thank you for saying some of those things. I mean, though you're taking a stance on stuff that I think is, you're standing up for a lot of people who are in pain and not getting the treatments they need. So I thank you for standing up for those people and saying what needs to be said in all those different areas. I appreciate that. You were kind of giving us a little bit of an idea of the science of pain and how it works. And I kind of want to repeat some of that just because I don't want that to get lost on anybody. And I know that some of the technical and scientific language can be a little bit confusing, but just talking about kind of the structure of like, why do people feel chronic pain? I know you were kind of going at that from a few different angles, but would you just give the listeners a little bit more of the picture of, why is it that they're feeling their chronic pain?
Well, there's a lot of, the person in front of me, you have 3 people with chronic low back pain. They can be feeling chronic low back pain for 3 different reasons, right? Many different reasons, multifactorial. But if I had your audience close their eyes for a second, okay? And let's say you have low back pain upon waking, right? That can be position-based. Like if someone's extension intolerant and they fall into extension during sleep, they might be jamming facets, causing a localized response, right? You could have eaten the night before something that made your blood sugar shoot up, and you have a little bit of trouble with blood sugar handling. Diabetics are known to have 3 times more back pain than people that are non-diabetic, right? So blood sugar plays a factor. So maybe they ate something. Maybe they didn't extend their back at all. Maybe they ate something and then went into a gentle amount of movement and then lit up the blood factors of why we feel pain. Maybe they're redheaded and blue-eyed like I am, which means you have tumor necrosis factor A just a little bit higher, so you have a little bit more pain awareness than other people. Maybe, you have complications due to neurological conditions like exposure to Lyme. Like chronic Lyme patients tend to feel more neurological delays and more amplified, pain reception. So if your doctor, if your therapist, whatever, whoever you're going to for your discomfort, is not investigating the many reasons why our human experience feels pain reception, go elsewhere. If the only thing they have to offer is, here's a Voltaren, here's an anti-inflammatory, here's an aspirin, here's a shot, then I believe in patient advocacy, and particularly one advocating for themselves. But doctor, why am I feeling the discomfort that I'm feeling? Well, when a patient says that to me, they've already filled out my 13-page intake, which helps me to look at their systemic reasons. They've sent me their blood work. They've sent me their images. So I can look at the structural and functional reasons, which may predispose someone to feel discomfort. And then, you go through a biomechanics analysis because mechanoreception can increase or decrease pain, depending on how one moves. And then you're looking at the blood, and then you're looking at whether weather affects it or temperature affects it. And so if you keep it simple, your doctor should be asking you all 3 of those major questions: thermoreception, chemoreception, mechanoreception, how you move, what's in your blood, and whether or not you're affected by baroreceptive changes, chemoreceptive changes, thermoreceptive changes. You should be having someone investigate all of those things. And if they're not, go elsewhere. But I can't tell you why people feel chronic pain, because it might be completely different for the people that are in front of me. Can I tell you why I feel most people feel chronic pain? Because they have had an attenuation, a sensitization towards self-protection. And what most of the time they'll do is attempt to get out of it. They'll forget that pain is there as a protective mechanism, and they will dampen it and then keep doing the thing that might get them in trouble. Like, for instance, if let's say someone feels back pain and they take an NSAID, non-steroidal anti-inflammatory. Let's say they take a over-the-counter ibuprofen or Relief, right? Naproxen. So they take that knowing it's an anti-inflammatory, right? Pain can have an anti-inflammatory or have an inflammatory response based upon chemoreception, right? So they'll take a chemoreceptive factor like a pill, and then they'll get a couple hours of not feeling awareness. Now their alarms are down. And then they'll keep doing things that put them right into perceived threat. Even though they don't feel the pain reception, they will move in ways that do not serve them. For the low back patient, maybe they move into flexion positions where they're flexion intolerant, extension positions where they're extension intolerant, rotation where they're rotation intolerant, and not doing full body load share like we teach in Immaculate Dissection. They're bending through spots that actually encourage pain awareness. And then they don't have a symbol to tell them not to do it. That's the thing that's wonderful about pain, is it tells you what not to do.
Right.
But there's no reception there to tell them to stop. So they'll continue to do things. And maybe they're eating things they shouldn't be eating. Maybe they're thinking things they shouldn't be thinking, all of which can control the chemoreceptive factors. Maybe their neurotransmitters, are faulty. Maybe they don't have the electrolytes to produce really quality, good nerve responses. And then now they don't feel pain to limit them. And so when that anti-inflammatory wears off, what inevitably happens? They feel pain, and it's usually worse than it was before. Because their body now amplifies the nociceptive response. It says, oh, wait, but they're in danger. Pain is not a faulty mechanism. Pain is, you're the product of 3.9 billion years of evolution. If you did not need pain, then you would have evolved out of it. And so that is a big, big empathic statement to accept upon oneself. I am extremely compassionate towards my patients, but I will not let them continue to cover up their pain in an attempt to try to understand it. That is not the way that you understand discomfort.
Yeah.
I'm not saying like pain, no gain either. I'm just saying that, if we're going to ask medical doctors to increase their educational purposes on the way that pain is perceived, then we have to take personal responsibility that when we show up at the office, that we're willing to do better descriptors, not cover up our pain all the time, and that we're willing to accept any advice that may help us get out of pain for the long run, but we may have to experience a little bit of pain in the short run.
Right.
And a lot of patients feel pressure. They pressure their doctors to get them out of pain now. Right now. So we have to take a patient responsibility to be patient and to let them practice helping us be patient. And in their practice, they have to understand the patient and how to be patient with their own practice of understanding, investigating. And so most people are not patient enough, I mean, the doctors and the patients, to really get to the root of why one is feeling it. And so they're just, we're falling into traps of just covering it up.
Yeah. Yeah, it's true.
That's what I did this for years.
Yeah,
for years. And it didn't work. And when I finally said enough already, I'm going to not get adjusted twice a week anymore. In fact, maybe I'll get adjusted once a month just to get things kind of moving. But then I'm going to have a respect for this nociceptive process of telling me when I'm in danger. And then I'm going to look at my blood deeper. I'm going to look at all the reasons why we feel the amplitude of the discomfort that we feel, and get more to the root of the epigenetics of why we feel pain. And the environment around pain, I think, needs to be educated more. But we have to if we're going to ask medical doctors to increase their curriculum to better understand pain, then we as patients need to be very patient with that process. And some of us aren't. I wasn't.
I mean, you're right. And I think for a lot of people, I think it comes down to responsibility. And I think that a lot of patients, a lot of people who are in pain don't necessarily want to have the responsibility for their body or for their pain even. And it's interesting when they come in with that complaint, when you look at it, it's sort of a contradiction when people come in and say, oh, I don't want to have pain anymore. Because like you're telling us, pain is such an amazing function that gives us so much good information to help us with our body. And if we just want to numb that and get rid of it, I mean, you're trying to lose function in your body. And people think that, oh, I'm going to gain function, I'm going to gain movement, or I'm going to be able to go play sports and be fine. But as you were laying out, it's like, it's a false function. It's a false supply that your body doesn't really have. You're just kind of masking it. So people ask, hey, take away pain and give me more function in your body. Really, you're losing. It's a lose-lose. You're losing pain, which is a healthy function that you need to have, and you're losing some of those other functions too. And if people would have that sense of responsibility, this is my body, this is what I need to be taking care of, I need to own this, I think that we would see some really big changes in the way that people get treatment, the way they interact with their doctors, the rate of different illnesses and decline that we have in our health and society. Absolutely.
Yep.
Yeah. Do you think, for people who, people who aren't necessarily the anatomy lover that you are, for people who are, having an invisible illness or having some kind of condition, I mean, how, they need to take on that responsibility, but how much should they be learning their own anatomy and really trying to dive into exactly what's going on with them? Do they need to know everything that we were talking about here? Or, how much should they be having somebody help them? I mean, how much is that balance? Because, like your own story, it's like at a certain point when you have a condition, you almost become a doctor sometimes, learning all of this stuff. I mean, you spend, some people in pain spend so much time reading books and obsessing and learning all of these things, and it's almost like it's their new career, diving into their own health. I mean,
Yeah.
how ambitious do people need to be when it comes to them learning their own body and understanding their illness and anatomy?
It's your pain. It's no one else's. It's it's a huge responsibility to take, but you only get one body.
Hmm.
Protect it, learn about it. I'm not saying you have to be an anatomist. One of the things that I love about the Immaculate Dissection courses and the neurokinetic therapy courses is that they involve homework.
Hmm.
I don't expect my patients to know every single muscle in the body. It wouldn't even matter that they did. You know, I think one of the most fascinating things that people tell me is like, Julie, I want a digital download of your brain. Like, well, you wouldn't even know what to do with it if you had it, because I've made the dendritic connections, the neuron connections, to know what to do with it.
Mm-hmm.
So what I want to do is give the patient empowerment
Mm-hmm.
to, I'm not going to pussyfoot around you. I'm not going to say, well, I'm going to call it this little thingy. No, this is your internal abdominal oblique, and it's affecting your ability to centrate your femur, to center it up in its socket so that you can feel less hip pain.
Hmm.
So I want you to do this internal abdominal oblique movement while you're coordinating this movement of your thigh, right? And my patients come back to me. You should hear them talk to me. They say things like IAO, they say femoral centration, pronation, supination. They sound like, they're in a class of mine.
Wow. Yeah.
What's wrong with that? Doctor means teacher, not fix your stuff.
Hmm.
That's why my gym is called Catalyst. My job is to catalyze them, not to fix them.
Mm-hmm.
My job is to make sure they can help themselves. In the great worlds of Dr. Carol Levitt, right? Best doctor of manual therapy, one of the best manual therapists to ever live. He said, rehab is teaching the patient how to help themselves.
Yeah, true.
They're showing up to learn how to help themselves. And I'm not going to apologize for having that kind of practice. I'm absolutely going to encourage my patients to learn their anatomy. There's anatomy painted all over my walls. And I do think that's why I'm an anatomist. I just wanted to understand the why of
Hmm.
how things occur and why do we experience it. And my patients always tell me, why? Why do I hurt? Why do I hurt? Because it's wonderful that your system would give you a signal to let you know that things are awry and worthy of your attention.
Hmm.
That's what pain is. It's worthiness, not something to be diluted.
Wow. That's really
So,
profound.
why
Gosh.
not learn your anatomy? It doesn't take
Yeah.
that long. One of my amazing teaching team members is not even in our profession. She's like an insurance salesperson, and she took all 6 immaculate dissections within 1 calendar year.
No way.
She took all 6. We have 3 people that took all 6 in 1 year. Not even
Wow.
her field. So she's just as astute as someone who's never had it. She never had an anatomy class before ID. So why not? And she studies every single day. And I would put her up against any physiotherapist I've ever met, any chiropractor I've ever met, any medical doctor I've ever met, to understand the way that the human body moves through space. I put her up against anybody.
Hmm.
And, I would do it in a heartbeat. I'm that confident in her because she works hard. She studies every single day. When did we get away from studying? We have the information superhighway that is the internet, but then we're looking and distracted by so many things that we don't have, maybe a focus. My focus just happens to be human anatomy. And the more I understand it, the more I can explain things with more ease. And the better my patients understand it, the more compliant they become.
Hmm.
If you know you're going to get results, like the complication of having someone with chronic pain is they don't believe they're going to get results,
Hmm.
right? Because so many things
Yeah.
have failed. They're
Yeah.
disheartened. They're discouraged. And if I can empower them by finally understanding why things hurt, the way that they hurt, the intensity at the level that they hurt, and then having the standard operating system that I use with ID and NKT, like those are the two cruxes, the crura of what I'm teaching to my patient. Doctor means teacher. I'm absolutely going to teach them as if they're my students in a class.
Yeah.
Yes, they will have to learn. Yes, they will have to study themselves 100%. I think them not studying themselves is what got them into trouble. When we go for a run and we zone out instead of tuning in, right? You think a run is meditative, you focus on your music and you tune out. You can't feel your right foot slapping harder than the left. Over time, you wear down, your low capacity meets your stability motor control, and then boom, you start to get tight, and then it starts to become painful, and then you're sensitized towards pain, and then you're trying to get out of pain, but now the injury's gone, but the pain's still here. And, I think that we need less tuning out, more tuning in, and pain is a wonderful way to make us tune in.
Yeah, it's true. Pain definitely gets attention.
Holy
Very true.
moly.
Yeah. Yeah. Well, beautifully said. Thank you for saying that. We've gone through so many things here, and gosh, I love hearing you talk. You can just go. You've got so many great things to say. I don't want to stop you, but you have so much great stuff to share on pain. And I think that you've really helped a lot of people understand, not only just how pain can work, but just, you've helped us do exactly what you said at the very beginning when it comes to learning anatomy. You've helped us realize how much we don't know, and that allows us to have humility and perspective on what's going on in our body. People try to simplify and make things so, just take this pill and it goes away. People try to simplify things in a way that does a disservice to what people feel and to the amazing complexity of the human body. And so I appreciate you bringing some of that complexity in, helping us to experience a little bit of that humility of understanding pain. And I think that a lot of people are going to appreciate these signals occurring in their body much more after hearing you. So I really thank you for that.
Oh, I hope so. I hope it doesn't sound like I'm being mean.
No,
because
you're being honest.
I feel like that's how it comes off. We like to kill the messenger. We want to kill pain. Pain's the messenger. But I want people to learn to befriend it, to let it in the door, to hug it and say, look, body, you've taken really good care of me. And now things don't feel great. And I need to respect the signal that you're giving me. It's just, pain deserves your respect, not your delusion. And the only way out is through. You have to understand. You have to really understand why your body is giving you the signal, and it is multifactorial. I wish, if in some ways, that it weren't as complex for some of my patients that are in so much discomfort. But the more the discomfort, the more that there is to understand. The depth of their understanding has to increase. And if pain awareness is the way to do it, the way to get them to change what they're currently doing, which is not working clearly, then bring on the awareness so that we can understand better about how to live a life that is more sustainably pain-free.
Yeah, absolutely. Well, Kathy, thank you for being on the show today. Really appreciate your time. Really appreciate all your insights and your wisdom. And, I appreciate your voice. I appreciate you being honest with your voice, being vulnerable with your voice, being a voice for people who maybe don't have the words or the space to speak what they're feeling or what needs to happen. I really appreciate you using that to empower other people. It means a lot. So thank you for being here.
Well, thank you so much. I really appreciate you having me on this amazing podcast.
Thanks for listening to this episode with Dr. Kathy Dooley. Don't forget to visit the websites in the show notes if you want to learn more from her. If you want to be involved with the podcast, there are 2 ways for you to do that. First, if you have any questions you want answered or topics you want us to talk about, then click on the BEET Pain website link in the show notes and message me. Second, if you want to continue listening to great content and guests, then I need your help to build the podcast and get those guests on the show. The bigger the podcast gets, the easier it is for me to bring on more amazing guests. Subscribing, writing a review, and sharing this with others helps this show to expand. Thanks so much for listening.